I thank the organizing committee for giving me this opportunity to come and talk about this topic today. So let's start. So diabetic retinopathy is a microangiopathy which is caused because of hyperglycemia. Now we know the small blood vessels are very susceptible and they generally do not tolerate high levels of glucose. So the global prevalence and burden of diabetic retinopathy, almost 22.3% of people today suffering from diabetes have DR, and 6.2% have vision-threatening diabetic retinopathic complications. And grossly over 103 million individuals are affected worldwide, which is 1 in 3. And the staggering question now is that the working population, the age between 40 to 50, are also getting affected by it every day. So the lifetime risk of developing diabetic retinopathy, there was a very good cohort study conducted on Wisconsin, and the study showed that over a period of 20 years, 90% type 1 diabetics have some degree of retinopathy, whereas the same percentage is 50 to 60% in type 2 diabetics. Now this is a very significant number. Then let's talk about a little bit about the pathogenesis. Normally what happens is that the glucose, it gets into the glycolysis and the Krebs cycle to produce ATPs, NADPs, which provide energy to the cells. But when the glucose molecules are very high in number, that is what, when the glucose is high, what happens is that the glucose is diverted towards the polyol pathways, creating advanced glycation end products, the reactive oxidative species, and sorbitol. Now these three are quite toxic. They cause membrane damage, they cause intracellular and extracellular protein malfunction, and they cause osmotic toxicity. There is also thickened basement membrane of the capillaries, and there is pericyte death. Now pericyte death, let's just take a minute here. Pericytes are the cells which sit on the basement membrane of the epithelium. Once these cells are lost, there is outpouching and there is microaneurysm formation. These cells cause endothelial cell loss further, and which results into hypoxia. Now we all know wherever there is hypoxia in the body, the vascular endothelial growth factors come into play, and that is when angiogenesis starts. But the problem with these blood vessels, these new vessels, is that they are very fragile. They keep leaking. There is leakage of blood, there is leakage of fluid, and that is what causes edema of the retina. Also, there is breakdown of blood-retinal barrier, which causes vascular hyperpermeability. So this is just a short video. Sorry. Okay, since it's not working, let's skip to the next point. So clinical symptoms associated with diabetic retinopathy are loss of central vision. The patients complain of blurred vision. Then there is fluctuating vision and eye pain. So talking about the risk factors, the most important risk factor is the duration of diabetes. The longer the duration, the more are the chances of developing features of retinopathy. So type 1 diabetics, as already mentioned, over the period of 20 years, almost 80% progress towards retinopathy, and type 2, 50 to 60%. The next important is obviously the control of diabetics, which is measured by glycosylated hemoglobin, HbA1c levels. Now there was a study which recently, Now there was a study recently which showed that every 1% reduction in HbA1c causes 35% reduction in diabetic retinopathy, and maintaining HbA1c around 7%, less than 7, really decreases and slows the progression of diabetic retinopathy. For hypertension, it's just a basic understanding that if the blood pressure will be high, there will be more leakage from the damaged vessels. So tight BP control reduced the progression and risk of vision loss by 47%, which is very significant. Lowering the blood pressure from 150 to 130 significantly reduced the progression of PDR. But here I would like to mention that lowering the BP below 110 also poses the risk of ischemia of the retina. So the ideal value should be around 120, 130. Also, increased cholesterol level means more hard exudates. Then triglyceride increase can also lead to production of diabetic retinopathy. Then the role of fenofibrate comes. Fenofibrate reduces the risk of reduces the frequency of laser in edema by 31%. Then let's talk about the normal retina. I don't know what's... Okay, I'll see. So here is a picture of the normal retina. This is the optic nerve head. Here the retinal arteries enter and the retinal veins leave. And this is the fovea. This is the macula. The peripheral retina is the neurosensory tissue. So all the fibers, they receive the light and then focus all the signals towards this optic nerve, which then conveys the signal to the brain, and that is how we see. So the vision forming center is this part of the retina. So now let's talk about the ETDRS classification. हाँ जी सर ना thank you so much sir. So the ETDRS classification is modified early house classification. In 1980s, a lot of ophthalmologists got together and they compared the fundus photographs, and that is how this classification was later modified in 1990s. To our surprise, however, this is still the primary classification system that is used. They classified diabetes into two types, the non-proliferative NPDR and the proliferative diabetic retinopathy. So in mild NPDR, when there are only microaneurysms, there is retinal hemorrhages and cotton wool spots. Now all these changes, they are reversible. You control the diabetic level and everything goes back to the normal. So you call the patient after one year, that's fine. In moderate NPDR, there are several severe retinal hemorrhages, about 20 in 1 to 3 quadrants. There is venous beading and there is cotton wool spots. Now venous beading is where there are pericyte loss, there is outpouching. That is why there is a sausage-like appearance, which we clearly see on retinal examinations. Then there is severe NPDR, where we follow the 4-to-1 rule. When there are severe hemorrhages in all 4 quadrants, there is venous beading in 2 quadrants, and there is moderate IRMA. Now IRMA is intraretinal microvascular anomalies. These are the shunt tissues which develop because of the hypoxia of the retina from the arterioles to the venules. These patients require surgical management sometimes, and they require very close follow-ups ranging from 3 months to 4 months. Let's show you a few pictures. नहीं आ रही अच्छा सर ये ना इतनी पिक्चर्स एनिमेशंस की तरह आ रही हैं से सारे वीडियो नहीं सर पिक्चर्स हैं let me try with this clicking. नहीं सर फिर वो पीछे ही है हाँ जी सर I'll show with this only then. I'll use the mouse, no problem sir. So these were actually animations, so I'll just show around. These whitish spots are the cotton wool spots. These are the lipid exudates which follow. These are the hard exudates. What happen is, this is the lipid, the macrophages which are lipid laden, and the more the cholesterol of the patient, the more this will cause problems. Now see, this is the optic nerve and this is the macula. Now such a deposition of macula, now this patient won't be able to see anything. So these are the hemorrhages. I hope. Yeah, these are the hemorrhages, and these are the hard exudates, and these small reddish, these are hemorrhages and microaneurysms. These are how we classify our diabetic retinopathy on the fundus examination. Most of our centers do not have very sophisticated machines like optical coherence tomography. So these methods still help us to diagnose the patients on daily basis. Then is the proliferative diabetic retinopathy. Now see, this is the optic nerve. This is the retinal vein. This is the retinal artery. Now retinal artery and retinal vein are differentiated by the presence of laminar flow in the arteries, and these fronts are all neovascularization. Similarly, this is also, this here is the venous beating I was talking about. This is the sausage-like appearance, and this is the neovascularization. Now these blood vessels will keep leaking, there will be vitreous hemorrhage, and the patient will have visual symptoms. Proliferative diabetic retinopathy is a huge problem for us, and this is when we have to do lasers multiple times, and these might need surgical intervention as well. Moving on, now this is what an OCT image looks like. This is the optical coherence tomography. This shows all the layers of the retina. I hope everybody remembers, we used to remember the 10 layers of the retina. So these are all those layers. This is the choroid, this is the vitreous, this is the retina, and the retina's basement epithelium membrane, the photoreceptor layer, and the normal foveal dip. Now this architecture, this dip is very important for our vision. Now what happens in diabetes? This is what happens. There is fluid here. Now that contour is lost. Now this is massive collection of water and whatever fluid is leaking. And because of the loss of the normal structure of the fovea, the patient will not be able to see. The next stage which happens is the detachment of the neurosensory retina from the pigment epithelium. Then there is tractional type. This is the membrane formation, and then this is taut posterior hyaloid. These two stages will eventually need surgical intervention. Moving on. Now the screening part, the most important question many of our colleagues ask us. So if a type 1 diabetic patient comes to you, that patient is insulin dependent and very early diagnosed. So send the patient to for retinal examination 5 years after the diagnosis. Retinopathy is a slow process. It takes time to develop. And then we have to see the patient yearly. However, if the patient is type 2 diabetic, we don't know since when the patient has that status. So whenever you diagnose a patient of diabetes, you have to send the patient immediately and for retinal examination. And then depending upon the stage, we further ask the patient to review with us annually or whatever stage the patient is in. Now if a diabetic female wants to conceive, that time we need to see the patient before conception and in the first trimester, and then every 3 months and first year postpartum. In gestational diabetes mellitus, we are not that much worried because in this, the chances of retinopathy are quite less. So the two important things, ischemia ho raha hai, edema ho raha hai. Ischemia ਲਈ ਆਪਾਂ laser use ਕਰਨਾ ਹੈ, and ਜਿੱਥੇ edema ਹੈ, ਪਾਣੀ ਸੁਕਾਣਾ ਹੈ, ਉੱਥੇ ਆਪਾਂ injections use ਕਰਨੇ ਹੈ, and we have to use steroids there. So we have to inform the patient for the need of multiple injections. The choice of injection depends upon the affordability. These are very expensive injections. Then we have to counsel the patient that the injection may not be 100% effective. And on the basis of the OCT thickness and the best corrected visual acuity, we decide whether to stop the infection or injections or proceed with them. So we get a diabetic patient. If there is no retinal findings, we call them after 1 year. If mild to moderate, we tell them to control their parameters and they can come after 1 year. All the changes are reversible, the hard exudates, they resolve, and every finding goes back to normal. If there is a severe NPDR where hypoxia is setting in, then we need to do pan-retinal photocoagulation. We burn the entire peripheral retina. There will be no place for the secretion of VEGFs and hence avoidance of complications. If there is proliferative diabetic retinopathy, then we need to intervene if there is vitreous hemorrhage, there is pars plana vitrectomy and other surgeries which are happening these days. The most common cause of vision loss in patients with diabetes is macular edema. If it is center sparing, go ahead with laser. The laser settings are very low parameters. And if the center is involved, now this gets very tricky. Here, if the vision is 6.6 or 6.9, the patient is satisfied, then do not do anything, kindly observe. If the patient's vision is less than 6.9, we have to go ahead with anti-VEGF therapy. Now, there are these 3 injections which we are using these days, aflibercept, ranibizumab and bevacizumab. Bevacizumab is the cheapest, but unfortunately it is still not approved by the FDA for ophthalmological use. It is used in colon cancer. Ranibizumab is a very good drug, and aflibercept is the most expensive, safest, but it costs around 40K to the patient, so it's not easily used these days. However, these 3 options should be given to the patient, and all 3 have the same result at the end of 6 months according to the Clarity study which was done in 2021. So the last few slides, we have to optimize HbA1c. If there is NPDR, kindly only observe. Retinal laser is the treatment of choice. In edema, we have to use anti-VEGF and steroids. If a patient has undergone cataract surgery and they already have implant in their eye, then steroid is a very good option. Steroids otherwise cause cataract, so we do not give it to the patients who have not undergone cataract surgery. These are how the implants look like. They are very tiny. We inject them into the vitreous cavity. They stay up to 6 months there. The cost is 25,000. This is dexamethasone, and the other one is fluocinolone. It is used, not yet approved by FDA for the use in diabetic macular edema. However, it is used in uveitis. The life is 36 months, and it is non-biodegradable, does not cause any problems. Next is the surgical management. I'm not dwelling into the details. So this we have already discussed. PDR needs treatment monthly. Edema needs monthly basis follow-ups. So takeaway messages, please maintain HbA1c less than 7. The blood pressure control 130/80. Type 1 diabetics have more common features of retinopathy. The patient to be sent for first retinal examination, type 1 after 5 years, type 2 at the time of diagnosis. Thank you for your patient listening. Thank you.